Okay, my name's Mark. I'm a 59-year-old male, and I've got a chronic upper cervical.
We can't hear.
Speak up.
You can just switch it on.
Oh, sorry. It's on.
It's on.
It's on.
59-year-old male with chronic upper cervical discomfort. Been involved. I was involved in a couple of motor vehicle accidents when I was younger, non-driver. Just this chronic niggle. Every now and then I get some osteopathic treatment which calms it down, and a little bit of acupuncture on myself every now and then to calm it down.
Can you tell us a little bit more about that pain in the neck? Where does it occur? Does it go anywhere? What makes it worse? What makes it better?
Occasionally it will create headaches, tension headaches, mainly on the right side. It's just this chronic niggly discomfort.
Anything make it better?
Bit of soft tissue work that eases it off. A little bit of acupuncture every now and then. Might take an anti-inflammatory as well.
What makes it worse?
Probably excessive amount of work. I do a lot of body work as well as acupuncture, so bending. That's about basically what it boils down to.
Any more questions from the floor?
No, range of motions.
No, that's in the examination.
Oh, sorry. Have you radiating pain down?
No radiating pain. No, just localised. No, just localised, mainly in the neck. Occasionally, it'll create like a gallbladder style headache. Occasionally, that's when it's at its worst. But I normally jump on it well before then.
How long have you had glasses, Mark?
Probably 15 years.
Any changes recently?
No.
Any other questions?
No.
Okay. Now, what I do normally is I start off with a little bit of an examination before I do the YNSA examination. So just looking at him here, I always like to stand behind people who have got neck problem. So I'm looking at his neck here, and you may like to take this one if you can. Are you able to come across? On his neck itself, there's some changes that you can see there. You may have to actually get up and take this. Or can I get you to turn for him? All right. You can see some creases. Can you see that? There's one here, and there's some more like across up here as well. And more like at an angle. Now, this tells you something, okay? The one that going straight across, you can bet your bottom dollar there's this degeneration there. All right, so this will be more in line with chronic injuries or consequence of chronic injuries, where he's got this degeneration at about C5, 6 level. So if we do an X-ray on him, I can bet you we'll see probably degenerative changes in that vertebrae, plus also a desiccation of the disc. That means that the disc space is a little bit narrower. Can we have some of the lights off so that you all see what you're writing? Yeah. Can you all see at all? Yes. Okay. So you can see how clearly that is. Some of the one at the side like that, can you see that when it's like a line that goes transversely there, not straight across, but at a slant there, they usually signify facet joint problem.
So you repeat that?
Facet joint problem. So if we're looking at that, it is actually very high up in the area, around about C2 level. Is where the thing finishes. So this already gave you, just from observation itself, without even doing any range of movement, you already see he has got several problems in that area. Okay, so this is just looking. So the next thing we're going to do is to get Mark to move his neck, and I do a very simplified range of movement. So what I'm going to get you to do, Mark, is to turn your head side to side. So if I'm looking, sorry, I can't see. So if I get him to move there, and you want to see how much of the face you can see on that side, and now turn onto this side. And there's a little bit more restriction. I'm assuming that Gavin is right in the middle there. All right. So you can see that you don't see as much of his face on this side than that side. So there's some restriction. Either there's something jamming this side or there's something restricting the movement on the other side. Make sense? Okay. The next movement I do is getting him to drop his head onto his chest, and I measure how many fingers breadth there is from his chest to the chin. And in this case, he's got 2.5 finger breadth, which is well within the normal range. For him, I think I'll expect 2 to 3 fingers breadth as being fairly normal. I think any more than that is really not normal. Now, looking at which part of the neck is involved in whatever movement, the upper part of the neck is more likely to impact on the forward flexion, forward downward movement, than the lateral rotation. The lateral rotation is more governed by muscle that's further down, or by the neck that's a little bit further down. Okay, so that's just a little bit of quick pointer on what you can look for. All right, so we're having do that. Can I get you to sit the other way now? We're going to do the hand diagnosis. So I'm going to sit in front of you so that we are both in the same frame for you. Is that good enough? Can I have your hand? And I like to examine the LI4 this way. So the hand is, your hand is cupping. My hand is cupping his hand. And I just run these two up and down. And there's a slight, are you feeling any sensitivity? Okay. There's a right restriction, more tension on this side. On this side. Which is the side actually when he was turning his head was a bit restrictive. All right. So, Peter, can you write on the board? So the next bit I'm going to do the elbow diagnosis. Following this side, I've determined that this is slightly worse than the other side. I'll start off with the basal ganglia, and his is perfectly okay. You're a good candidate. You can remain relaxed while I'm doing that. So this is basal ganglia. I move inwards to the cerebrum, which is also okay. Don't think you're tender. Then on to the cerebellum. And there's a little bit of sensitivity in the cerebellum. The next bit I'm going to examine is his neck point. And it's on the lateral here, and there's some sensitivity, which he will agree. The next one is the thoracic in the middle here, and there's nothing really much to speak about. For the back, I'll go through the back first, and that's quite okay, quite clear. Having done that, we already observed that it's mainly the cerebellum, is that cerebellum, and also the neck. Just CBL will do. Now, with the neck diagnosis, can I get you to turn your leg the other way so Gavin don't have to come? Yeah, all the other one don't work. As usual, and I haven't got a big one, I only got small ones. Did you?
Where it went. I'll get some of the,
Because these are, you can use this black one, but I don't think it's going to be, I think it's going to be a bit fine.
Should be okay.
Is that better? Too fine, isn't it?
I will.
You're going to do a lot of editing, I think. I think just CBL will do. Don't have to write so much. There's a rubber there. There's a rubber there. And it's that piece. With the, okay? With the neck diagnosis, so we're going on to the neck diagnosis now, and I just run through very quickly here. So I'm looking to see where his SCM goes. And sorry, you can if you want to, just to show you where it is. Sorry, push against me. And you can see where his SCM finishes there. Okay, sorry, you've got another head actually. So that's the SCM there. I'll be at the kidney point, the bladder, and the spine. And he has actually got a knotty bit on the spine. So what I want you to do is maybe Tom, Dick, and Harry, you want to come and feel this? So this is part of the teaching one. Is that okay? All right. So on the spine, if you run your finger from kidney along the spine, it's more as you drag out towards the outside. So we are looking at kidney, lumbar, and then the head is over this other end. So as you, no, don't dig like that. Slide.
Slide.
So slide. You feel it?
Yeah.
Okay. So do you feel that little knot?
Yeah, just
Towards the end, isn't it?
Yeah.
That's the cervical region. Naughty, right? He's very naughty, yes. So we got that one done. Now the next bit is the liver, and I just run this very quickly, and that's also taut. Feel it again. Just do it very quickly because you're going to feel it a bit later.
Yeah.
All right. So having found the liver, we move forward to the pericardium. There's a bit of sensitivity there. Heart and gallbladder. Gallbladder is okay. Only a little bit of sensitivity in the pericardium. Yeah. That actually it got rid of it. The next bit I look for is the small intestine, and I drop down to the large intestine, moving forward to the triple energizer, and that's also a sensitive area. Am I right? A bit sensitive or tight? It's tight anyway. Okay. You can feel this too. If you slide it forward, you'll feel it. So if you put your finger there, so not there first, here, lighter. Slide forward now. So slide your finger forward. Yeah. You can feel a bit of tension there. You can have a quick feel. Okay. Right. So we've got that one done. Triple energizer. We come back to the stomach and the spleen. So stomach here, spleen forward. The next bit, I think, is the lung, which is fairly easy. You just do, sorry, I'm in a bad position, but I want to show this. I think that's good enough. Looking at that. So there's quite a few little things. I'm going to run through just the other side, but very quickly. I won't ask you to do anything, but you can stay put because you can find whether those points disappear when we treat. So over this side, I'll be looking at basal ganglia again, and that's perfectly okay for basal ganglia. I'm looking at the cerebrum. That's okay. Cerebellum, passable. Neck, not as much as the other side. There is a little bit there though. I don't know if you can feel that, but there's a little tiny bit, but the other side is very marked. So that's it there. You can feel a bit there. Thoracic area and the back, lumbar region. And that's okay. So is the finding that we've got there is mainly on the head there, on the brain point, we've got the cerebellum being positive, and then the neck you saw already on the examination, and also on the diagnostic on the elbow is worse on the left than the right side. You already saw earlier on when he did the rotation that there was a slight limitation on the left side. So it correlates very well all throughout, okay? All right, so what we're going to try and do now is to treat. Bring your leg back the other way. I'll have to find some needle. That will do. I like to keep counters, okay? Because we don't want to have any problem with not being able to match up the number of needles you use. So I usually keep the paper part as a counter, not the tubes, mainly because when you use the tube, it can roll away and you lose it. You can use a little container and put that in so that you keep the count. So I'm just going to keep that as a counter. And I've got a needle all ready to go. So I'm going to go back to the point. So a lot of the sensitivity is in that you already found out what it was. We've already got
Neck.
cerebellum, neck. Okay, so cerebellum, can I get just one of you, feel for the cerebellum again in the elbow diagnosis? Yeah, cerebellum. Has he got it?
Yeah.
Okay, just keep your finger on it, but very lightly.
Okay.
Don't push in, just lightly.
Mm-hmm.
So we're going to use the cerebellum. So I've got to find his upper crease. Yeah. And his cerebellum will be behind the cerebrum. The brain point goes up to about C6, cranial nerve 6. So cerebellum will be somewhere around here. Yeah, I think this is, you can feel, you can feel something happening, can you? And I think he should feel something happening. And I'm just going to needle from here down. What does that feel now? Is it lighter?
Yeah, you can actually feel it pulsating.
Change. All right, so we go on to the next point, and you want to change swap places for the neck? What should I use for the neck? Lateral rotation. Where's the needle gone? Sorry, I'll just go for. I need to get to the needle, sorry. Yeah, and I'll just not keep this one. Okay. You all get a chance to do it because we're just going to do it in groups so you can have a feel of what we're talking about, okay? So it's not just these two have been privileged. So we're going to use the neck point. Can you feel the neck?
Yeah.
And it's taut?
Yeah,
Identify that. Just keep it lightly. Keep your finger lightly on it so that you don't lose your position. I'm going to use the J somatotope. And that's it there.
Yeah.
Is that gone?
Yeah.
You can feel it go straight away.
Yeah, you can feel a sudden pulse almost right there at the point as you're putting the needle in.
Yeah.
It's an instant
Response. It's all in real time.
time. Yeah.
Okay? So what else do we have there?
Liver.
The neck. I think the neck is good. What do you put the other one?
Right basal ganglia.
Right basal ganglia. Okay.
That was the right neck. Do you want to do the cervical, the ipsilon, spine?
Let me see. Because if this already clears it, no, there's still something there. The neck is still something there, so it isn't finished. I'm just going to modulate the needle. That's gone. Okay? So that was only a half anti-clockwise turn that actually changed the texture. That you can feel it's gone. Just slightly, just slide from side to side this way.
Yeah, it's loosened up.
Yeah, it's loosened up. Okay, so then we got, sorry, the neck one. What's this?
Right basal ganglia.
Right basal ganglia. So right basal ganglia is still there. So let me find your right basal ganglia, which will be fairly near the center there. If sometimes you can't palpate anything, just rough up the area a bit. The points will then start to show again. It's a trick that Dr. Yamamoto taught us. Rough it up, and there it is. That's gone.
So see how this neck right there?
Okay, can we get you to get the chair the other way again so that we can get Gavin to take directly on? Sorry, I'm going to turn your chair the other way. Oh, okay. So if you are dead center,
Mhm.
all right, can you turn to the left and turn to the right? Virtually the same, right? So he has already changed quite a fair bit there. That's only with 3 needles only.
And when will the creases on his neck?
No, it won't. It won't. Because they have lost fluid. The disc has desiccated.
Yeah, okay.
You're not going to get it. We can always try and pump something into there.
No. Hold on.
Silent stick?
Hold on.
So in Japan,
You feel okay? How does that feel to you? Feels good? All right. So we've done one case, so we're just going to move on to the next one now. All right.